Today we're going to talk about the trophic and the peripheral corneal ulcers. So we have already got the background knowledge towards the different kinds of ulcerations that can occur in the corneal epithelium. Ulcerations, as we all know, are defined as basically a breach in the epithelium of any structure. So here we're going to just discuss or summarize the reasons behind a breach in the epithelium of the cornea. We all know that we have the infective causes towards the development of this breach in the epithelium, and the infective causes would basically range from the bacterial origin, as well as it can be due to the viral infections. The protozoal infections, for example, the acanthamoebic infections, can also result in this breach in the epithelium that is caused. Now, the complications are quite variant over here. It can even result in a complete loss of vision if these corneal ulcerations are ignored and if they're not treated. One of the important variants over here is, regardless of the infective causes, we have the other miscellaneous causes. For example, we have the degenerative causes towards the development of these corneal ulcerations. Now, you might wonder what may be the triggering factors towards the development of this degeneration. This can be some sort of the autoimmune disorders, of course, and then we have a lot of syndromic conditions that we will go through subsequently in our lecture, and that is basically going to highlight the different causative factors that mount towards the development of corneal ulcerations in these individuals. We also see these specific causes that contribute towards the development of marginal ulcerations. That is basically the ulcerations that develop towards the limbus of the eye. When you recall the applied anatomy of the cornea, you would recall that basically the margins are in close relationship with the conjunctiva, and this point is basically known as the limbus. So that is basically the ulcers that would be residing near the limbus would be regarded as the marginal ulcerations over here. So this is the topic of discussion today, and we'll be going through these interesting facts that basically relate towards the development of these trophic ulcerations and marginal ulcerations. Knowing the basic histology of the cornea and having the background knowledge towards the histological features of the cornea is again very important over here when we are going through the causative factors towards the development of this particular kind of classification, which is termed as the trophic corneal ulcers. The name trophic, that basically the word that pops in your mind should be the degenerative processes that occurs in the cornea. And that basically results in this epithelium breakage. Obviously, due to this break in the epithelium, there are going to be the irritative factors that come into process. And finally, it's going to be an inflamed condition in the conjunctiva. Usually, these patients present to you with a red eye. And one of the major factor that is very important when you usually come across these trophic corneal ulcers is the corneal insensitivity. So it's again very important that when these patients come up to you in the outpatient departments, you should know how to diagnose and how to get to a final diagnosis and how to know that this particular patient is suffering from this trophic kind of corneal ulcerations. Usually the major symptom over here in these patients would be a decrease in the sensitivity of the cornea, and of course a red eye, signs of inflammation, signs of congestion would be observed in the conjunctiva as well. So these would be the particular features that the patient would obviously complain of, and as well as you're going to look for these signs as well. Is the patient suffering from some sort of a corneal ulceration? Are there any signs of inflammation? So you're going to carefully and closely examine this patient under a slit lamp, you're going to look at the major features of the corneal ulcerations over there, and of course use any sorts of immunofluorescence staining techniques just to highlight the shape and the intensity of the ulceration that it has caused. Now, majorly, when we have a look at these trophic kind of ulcerations, we have these two major categories over here. One is the neurotrophic keratopathy. As the name is indicating, it is basically the corneal ulceration which is resulting due to a nerve damage. Now, this nerve damage, of course, can be a condition which is a by birth condition. For example, a lot of syndromes in which the blinking of the eye is sabotaged, and that is basically the causative factors towards the development of this neurotrophic kind of corneal ulcerations in these children. As well as we have the other acquired conditions, for example, a lot of autoimmune disorders, as well as any trauma which is encompassing the Gasserian ganglion, that is also going to result in this particular kind of neurotrophic keratopathy. Keratopathy, as the name is indicating, it's not just the development of the ulceration in the cornea. It's the involvement of the cornea as a whole. So you just recall that when we know, or when we have the background knowledge towards the applied anatomy of the cornea, we can remember that we have these 5 most histological layers of the cornea that were very important. First of all, what kind of epithelium does the cornea have? It has a stratified squamous kind of a epithelium, and again it is subjacent to a layer of columnar epithelium which has tight junctions, which also provides protection to the orbital structures, because cornea is basically a transparent rounded structure that is present in front of the iris and obviously in front of the lens. The basic feature that it has is its transparency. So if there is any there's any condition in which the transparency is affected, it is going to finally result in a decrease in the vision of the patient. So this is how you basically calculate, and this is how you assess the patients when you're examining the eye of the individual. Then moving on, we have the stromal layer in the cornea, which is basically having the fibrils, and that again has its own kind of lattice meshwork over there that is basically giving off the transparency to the cornea. So that was basically known as the Morris's theory of the transparency. When we read why the cornea is transparent and how is it kept transparent, there were different factors that were contributing towards the transparency of the cornea, and one of it was the arrangement of these fibrils that are present in the stroma. After the stromal layer, we have the Descemet's membrane, and then finally we have the internal limiting membranes. So this is basically the whole anatomy or the whole histological features that we studied over here. And over here, we're just talking about the ulcerations, but it's just not limited to the ulcerations of the epithelium. Sometimes the word keratopathy is used instead. And that is basically indicating that even the stroma may be involved. Even in a lot of cases, the Descemet's membrane is involved in these patients. So the infections and this degenerative process can even travel down to the level of the endothelium, and even the perforations of the cornea they can encompass in a lot of patients. So one of the variety that we studied over here is the neurotrophic variety, and on the other hand we have the exposure keratopathy, which is also termed as the keratitis leg of ophthalmos that we would be discussing over here. So getting into the details of the neurotrophic keratopathy just reveals the factors that we have the different categories even over here, or we can even subclassify this kind of the category into the acquired conditions. Then we have the congenital conditions that would finally result into this neurotrophic kind of keratopathy over here. So we have these variants over here, and as you can see, we have the different causative factors, and we can subclassify this kind of the keratopathy even over here. The congenital causes would consist of the familial dysautonomia, which is also termed as the relay day syndrome. Then we have the congenital insensitivity to pain. So we have already discussed it over and over again that the major factor or the major pathology over here when we have this neurotrophic keratitis or neurotrophic ulcerations is the insensitivity. This would be the major symptom that the patient would complain of on and off. And in all of these syndromes, they are basically suggestive of this relay day syndrome, or either it is the insensitivity to the pain. Anhydrotic ectodermal dysplasias are one of the variants that again would result in this congenital kind of neurotrophic keratopathies. The acquired conditions are going to be, in this state, we have the, it can follow basically the alcohol block or the electrocoagulation of the Gisserian ganglion. This alcohol block or this electrocoagulation can be a part of another treatment if it is going on. For example, in trigeminal neuralgias or even in neuralgias that are associated with herpes zoster, sometimes this kind of a block is used to block the neurotransmissions of the pain from the Gisserian ganglion. So over here, this is one of the complications that is related. Sometimes these patients would present to you later on that they are suffering from a kind of insensitivity in the cornea, as well as there are development of the keratitis, or there is the complication of the keratopathy that is noted down in these individuals. Even a neoplasm, so tumorous conditions, can pressurize the Gisserian ganglion, and finally it can result in the insensitivity to pain, insensitivity to touch of the cornea, and that is ultimately going to result in the ulcerative keratitis or just the keratitis, even the exposure keratitis, for example. The Gisserian ganglion destructions, and these destructions can be a part and parcel of any of the traumatic conditions, as well as it can be during a lot of operations that these Gisserian ganglions can be destructed during a part and parcel of the surgical procedures that are carried out. For instance, the typical facial surgical procedures that are carried out sometimes result traumatizing this Gisserian ganglion and resulting in the neurotrophic kind of keratopathy. A lot of infections that can result in the Gisserian ganglion. For instance, if you remember, we just discussed the herpes zoster virus. Now, this herpes zoster virus is basically the chickenpox virus, that is the varicella zoster virus that the child is being infected by. And then this varicella zoster virus basically becomes dormant and it resides in the Gisserian ganglion. Sometimes whenever there is a decrease in the immunity of the individual, there is a reactivation and regeneration of this herpes zoster virus, and it can then just travel back to that particular area and cause these shingles, or which is also known as the herpes zoster ophthalmicus. So we know all the features of the herpes zoster ophthalmicus. That is a different domain, but over here we're just considering the fact that if the Gisserian ganglion itself is infected, then this state is going to basically result in a neurotrophic kind of keratopathy as well. So this would be one of the complications that can occur with the infections of the herpes zoster virus. Then we have the syphilitic neuropathies, and syphilis is one of the infections that can travel up to the Gisserian ganglion, and that is again going to result in these keratopathies. The involvement of corneal nerves, for instance, there are a lot of systemic diseases that can result in the neuropathies. For example, we all know about diabetic neuropathy, as well as leprosy can even result in damage to the neurons and the neuronal structure on a whole, and that is again going to result in the final outcome of the neurotrophic keratopathies in these patients. We've already discussed that any trauma or any injury to the Gassarian ganglion, either it is an acquired injury, an external injury, or either it is some sort of a systemic debilitation that can result in the damage of the Gassarian ganglion, will result in a neurotrophic keratopathy in the individual. The pathogenesis that we have all come to know is the damage to the sensory nerves that occurs in the neurotrophic keratopathy, and that finally results in the metabolic activity of the corneal epithelium, which is disturbed in these patients. As a result, there is an accumulation of the metabolites, and which is finally going to result in the edema and the exfoliation of the epithelial cells. So this is basically a step-by-step procedure. First of all, the nerves are damaged, and that in turn basically debilitate the metabolic activity. There is an accumulation of metabolites, and as a result, there is edema that is noted down at the corneal epithelium. The location over here is very important. You have to remember that all of these features are basically affecting the epithelium of the cornea. First of all, there is going to be an accumulation of metabolites over there, and then there is an exfoliation of the epithelial cells. So it's not the infectious state, it's not the inflammatory cells that are accumulating at the epithelium. It's basically the degeneration that is occurring due to the accumulation of the metabolites. Over here, we just had basically proved the fact that it's not the accumulation of the edematous cells or not the accumulation of the macrophages or the lymphocytes that were the usual cells or the usual cause towards the damage of the epithelium when we discussed the infective causes towards the development of corneal ulcerations in bacterial keratitis and in viral keratitis, or even in protozoal infections, for example, the acanthamoebic keratitis, or even the ulcerations that are caused due to all of these infectious states. So final result is the development of ulceration that occurs at the epithelium. There is a breach in the epithelium that is the final outcome of all of these processes that are taking place. Then finally, the symptoms that the patient would come up with. What would be the typical picture that the patient would come up to you with? The symptoms would consist of a red eye. So there would be always the signs of congestion that you would note down in these patients. Either it is at the conjunctival margins, it is at the limbal margins, or even the cornea is going to be sought out to be irritated in these individuals. The swollen eyelids or the blepharitis kind of a condition arises in these patients. Then we have the defective vision. Of course, we've already focused on the fact that cornea is responsible for the transmission of the light rays or the imaging to the retina. So if there is any hindrance in the transparency of the cornea, there is a cloudiness in the cornea, or there are any keratopathies resulting in the ulcerations of the cornea that are going to block the final imaging that forms at the retina. So there is going to be a defective vision that the patient would complain of. No pain and no tearing. This is one of the distinguishing features over here. We've already discussed that there is pain that is associated with bacterial kind of keratitis, as well as with the viral keratitis, as well as with the protozoal kind of keratitis. While over here, you can just focus on the fact that there is no pain as well as no tearing or no discharge that is seen. So no mucopurulent discharge, no follicular keratitis that is associated with it. So these are the distinguishing features. Whenever you have these patients of decreased vision, swollen eyelids, red eye, and you can see the ulcerations on the cornea, you don't know by sure whether it is an infective state or whether it is a degenerative state. So these typical points, that is, when you exclude that there is no pain and the patient also gives you the history that he's not suffering from any excessive lacrimation, that is no tearing, no excessive tearing, that is basically going to highlight, or that is going to point out towards the fact that this keratopathy is due to the degenerative causes, or it is the neurotrophic kind of keratopathy that the patient is suffering from. Then the signs. We see that the patient usually, when you're examining the patient will have a ciliary kind of congestion. The sensations are going to be decreased. As the word is indicating, we are talking about neurotrophic keratopathy. So the sensations are obviously going to be decreased in these individuals. The sheen is lost. Sheen is basically the transparency, the sparkle that is present in the cornea. So we'll have a dull sheen that is observed in these patients of neurotrophic keratopathies. There is the punctate epithelial erosions also observed in these patients, as well as the frank epithelial defects would be observed in these patients. Then finally, we see that these patients are suffering from the corneal ulcer formations eventually. Having all those preliminary signs of congestion and irritation and the loss of sheen, the patient would finally have the signs and symptoms of the corneal ulcerations also noted down. Now, moving on, when you have diagnosed these patients to be suffering from neurotrophic keratopathy and you want to treat these patients, you should know what are the treatment modalities that are present out there. That basically depends upon the drug of choice in these particular cases. The conventional treatment would consist of course, the prophylactic antibiotics we can use. Of course, we know that this is not an infective cause. There is no infection that is associated with this kind of development of the ulceration. But obviously, due to the development of the ulceration, the eye and the cornea is exposed to the superimposed bacterial infections. So we'd give off the prophylactic antibiotics in these patients. Then obviously, the typical conventional therapy when we give the cycloplegics. When we use the word cycloplegics, we basically mean the use of atropine. That is going to result in the dilatation of the pupil. And finally, we also prescribe the patient of the lubricating drops, for example, the artificial tears. And then we also ask the patient for the patching of the eye, patching of the affected eye, of course, just to prevent any other further infections or the further exposure of the cornea to any further environmental conditions. The special treatment would consist of the topical nerve growth factor drops that are being used. So a lot of research has been done on these neurotrophic kind of keratopathies, and we have finally come up with these topical nerve growth factor drops in which there can be some betterment in the nerve growth. So this is one of the factors over here. And then we have the autologous serum drops that are coupled up with these nerve growth factor drops. The amniotic membrane transplantation, of course, if there is the excessive ulceration noted down at the corneal epithelium and even the stroma is damaged, we would really go or opt for the choice of the amniotic membrane transplantation in these patients. That is one of the prostatic treatment that can be given to these patients. Finally, one of the treatment of choice that is usually done is the lateral tarsorrhaphy. So again, it's one of the plastic kind of operations that can be done if there is excessive damage that has occurred to the cornea of the individual. The amniotic membrane transplantation, it's basically when you take up the amniotic membrane and you replace the normal cornea of the individual with this amniotic membrane. And it's basically going to, again, you have to keep in mind that the amniotic membrane is transparent in nature and is going to play the function just as the cornea. It has again its refractive index and is going to pass on the light and provide the protective functions to the iris as well as to the lens of the individual. The lateral tarsorrhaphy is one of the treatment of choice over here. Now, this is basically done when we are basically giving the incisions at the tarsals. It can be, usually it can be the lateral tarsals that are used for this kind of procedures. And after performing this tarsorrhaphy, basically, you're going to limit the exposure of the cornea. That is, even if the cornea is insensitive, even if the blinking is affected in these individuals, you perform this tarsorrhaphy just to have this medial canthus and this lateral canthus approximated. This approximation is again very important over here, and this is going to limit the exposure of the cornea. As you can just observe over here, we usually perform these operations on the lateral borders, and usually this lateral canthus is approximated in these operations. And after these surgeries, the exposure of the cornea is limited, and that is the main aim or the major aim of these lateral tarsorrhaphies that are performed in these patients. The exposure keratopathy, we all know that there are the neurotrophic developments or the neurogenic developments of the keratopathies. We discussed that one of the causative factors can be any problem that is occurring at the neuronal level, and one of the other factors is the exposure keratitis. Now, when we use the word exposure keratitis, another terminology that is used over here is the keratitis legophthalmos. Legophthalmos can be termed as a terminology used for a lid lag that is used. We already studied the different factors towards the development of the lid lag. It can be neurogenic in origin, it can be any trauma, it can be any infectious states. Even in thyrotoxicosis, the patients usually present to you with a lid lag. So all of these factors basically contribute towards this kind of a lid lag. And as a result, the cornea is exposed to the environment. Once the cornea is exposed to the environment, there is a decrease in the blinking phenomena. Obviously, a lot of infections can occur in the cornea, as well as the superimposed infections can occur in the cornea. You would observe that these patients usually come up to you with xerophthalmos. Xerophthalmos is the idea of the dryness of eyes that these patients usually come up with. Even the patients present to you in the outpatient departments with a foreign body sensation, irritation in the eyes. So these would be the common signs and symptomatologies that are observed in these patients. The exposure keratopathy and the causative factors towards the development of exposure keratopathy, they include the extreme proptosis, and we have gone through the different development factors towards the proptosis. Proptosis was the outward protrusion of the eyeball, that is the forward bulginess of the eyeball was regarded as the proptosis. Apart from thyrotoxicosis, there were multiple factors towards the development of proptosis. It can be any tumorous conditions, any massive infiltrates, any autoimmune disorders that are occurring at the back of the eye and that are resulting basically in the forward protrusion of the eyeball. So the extreme proptosis is one of the causative factors towards the development of the exposure keratopathy, and we can also term it as the keratopathy or this exposure keratopathy is a complication of the proptosis or the extreme proptosis in these patients. Then one of the factors over here is the Bell's palsy. Bell's palsy is basically a condition in which the facial nerve is affected. The basic pathology towards the development of the Bell's palsy is not known, and it's basically of the idiopathic etiologenesis. But still, when the facial nerve is affected, it is going to affect the blinking of the eye in the contralateral side. So if it's basically the right side is affected, the right facial nerve is affected, then the contralateral eye is basically going to be affected in these patients because there is a decussation process that occurs, and that is going to result in the contralateral effectiveness in the fifth nerve palsy, or which is also known as the Bell's palsy. In these patients, the patient would basically complain of the loss of the blinking that is noted down at the contralateral side. So this is one of the causative factors towards the development of exposure keratopathy. Then obviously the ectropion of severe degree that can also occur in a lot of patients, and again there can be multiple factors for the development of ectropion. This ectropion can result from the tumorous conditions, from the infectious states, from the congenital anomalies. Whatever the cause may be, it is going to result in the basically the abnormal closure of the eyelid. So that is the causative factors towards the development of exposure keratopathy in these individuals. Finally, symblepharon is basically a cicatricial tissue that develops between the bulbar part of the conjunctiva and the palpebral part of the conjunctiva. So whenever this condition happens, it is going to result in the abnormal closure of the eyelid. Again, that is going to subsequently result in the exposure keratitis in the individuals, or finally the leg ophthalmos in the individuals. The deep coma that is associated with inadequate closure of eyes. So sometimes in a lot of comatose patients, these patients cannot close their eyes properly. And that is this condition, the comatose condition is going to result in the exposure keratitis in these patients. Then finally, the physiological leg ophthalmos that is observed in a lot of patients. The condition is idiopathic in origin, and there are no known causes towards the development of this physiological leg ophthalmos. So when you observe these patients during sleep, they cannot close their eyes properly. So this is known as a physiological leg ophthalmos. It is not associated with any neuronal problems or any other deficiencies. All of these are basically myths that are associated with this physiological leg ophthalmos, and usually the basic etiology behind the development of this physiological leg ophthalmos is not yet known. But still, it can result in the exposure keratitis in the patients. The pathogenesis would be the corneal epithelium basically dries up. This condition is known as xerophthalmos in these individuals. And that is going to result in the desiccation process in these patients. The epithelium is going to have a cast off that is going to be accumulated at its surface. And finally, there is going to be an invasion by the infective organs. So initially, it is not going to be an infectious problem in the eye, but final results would be the infections that are caused by the bacterial, or they can be the viral or protozoal infections in these patients. The cause was the basic dryness of the epithelium, which is making the epithelium more prone to the development or more susceptible to the causative organisms in the environment. So this is the basic pathology over here for the development of the exposure keratitis in these patients. The clinical features that are suggestive of exposure keratopathy are the symptoms would include the ocular irritation in these patients. They would also complain of a burning sensation, a constant irritation, the redness of the eyes that would be observed, a foreign body sensation, and then the congestion and the redness that is even noted down by the individual himself or herself. Then finally, the signs that you're going to look up for as an ophthalmologist, you should know what are the typical signs that you're going to look for in these patients are the dryness of the cornea. So when you're going to ask the patient to sit just beside you on the slit lamp, you're going to observe whether you can observe any dryness of the cornea. How is the sheen of the cornea? Is there any dullness observed in the cornea? That is going to be documented along with the initial investigations. The punctate epithelial defects are noted down in these individuals, and then finally, we can also come across the corneal ulcerations that are found on the surface of the cornea. Even you can use the immunofluorescence techniques for these purposes as well. The prophylaxis for the exposure keratopathy. So when you know that this person is more subjected towards the development of the exposure keratopathy, for instance, he has proptosis, for instance, he has been diagnosed with Bell's palsy, or he has or she has a physiological kind of a leg ophthalmos, no other pathology. But still, if he is more exposed to the development of some sort of exposure keratopathy, then you're going to start using some prophylactic drugs in these patients. And you should know how to educate the patients that why they have been prescribed with these particular kind of drugs. So artificial tears, just to use as the aim for lubrication, is achieved due to this fact, the ointment and the lid closure by the tape or the bandage during sleep. So you can even pressure close the eyes and just stop the exposure, stop the excessive exposure during the sleep in these patients as well. And then obviously the soft bandage contact lenses are sometimes prescribed as a prophylactic measure in these patients who are more prone to the development of exposure keratopathy on this behalf. The treatment that they would be prescribed with are the treatment of cause. So this is again very important. If the patient has high thyroid hormone levels, you're going to treat the definitive cause first of all. If it is a tumor that is residing behind the eyeball, and that is the basic cause towards the proptosis, that is contributing towards proptosis, and then finally the patient has the exposure keratitis. So you have to focus on the definitive cause, that is the tumor, not just the keratitis and not just the exposure keratitis. It is going to be the final diagnosis that you're going to make in these patients, and that's how you're going to start treating off or start planning the management in these patients of exposure keratitis. Tarsorrhaphies, mostly the lateral tarsorrhaphies, are advised for these patients, and these are the most important surgeries that can be done just to avoid any kind of inadequate exposure in these patients. Now we have another variety of the peripheral ulcerative keratopathies that we're going to observe. The types that we usually see over here are the peripheral ulcerative keratopathy associated with connective tissue disorders. So there are a lot of connective tissue disorders that usually present to you with this kind of keratopathies, even the Mooren's ulcers. You would observe that the usual development of the ulceration is the central portion that is affected. But if it's the periphery that is being affected, you're going to see that these degenerative causes are of the autoimmune origin. Mooren's ulcers is one of the chronic serpingus kind of ulcerations. It is also known as the rodent ulcerations in these individuals, and they are the most commonest kind of ulcerations that you would note down in these patients. The rosacea keratitis, it's one of the complications of the acne rosacea. So the patient would be usually presenting to you with severe acne on his or her face, as well as the butterfly rash on the malar and the nasal bridge. So this is the characteristic features that are associated with the rosacea keratitis in these patients. Then we see or come across the marginal keratitises, and then we have the Terrian marginal degenerations, we have the pellucid marginal degenerations. Whatever the degeneration or the kind of the degeneration may be, you have to look and just appreciate the shape, the size, as well as the location of the development of the corneal ulcerations in these patients. Flictanular keratitis is basically a kind of keratitis which has the development of follicles in it. So this is one of the kinds of the peripheral keratitises that you would observe. And then we have another variant which is known as the Dellon's keratitis. So these are some of the subclassifications towards the peripheral variety of the ulcerative keratitis. The causative factors over here would be the peripheral corneal ulcerations, of course, and then the patient sometimes suffer from rheumatoid arthritis, that is one of the autoimmune disorders. Then we can have the patients of systemic lupus erythematosus, that is SLE, polyarthritis nodosa. You would note down that Wegener's granulomatosis or any of these disorders, they're basically grouped under the autoimmune disorders. So that is basically going to highlight the fact that all of these autoimmune disorders can subsequently result in a peripheral kind of ulcerative keratitis in these patients. So we have the clinical features over here, and particularly when we are dealing with a peripheral kind of ulcerative keratitis, the peripheral acute corneal ulcerations are noted down. That is just along the margins of the limbus. Then we have a rapid progression that is noted down in these patients of peripheral ulcerations. And then finally, we have the inflammations at the limbus that are noted down. So limbus is the area. Limbus was basically the area that is subjacent to the conjunctiva, and that is more prone to the development of peripheral ulcerative keratitis in these patients. Finally, we have the peripheral corneal ulcerations, the peripheral corneal melting phenomena observed in these patients. So these would be the signs that you would observe in a patient of peripheral ulcerative keratitis. One of the variants is the marginal keratolysis. The treatment over here would be the topical medications, of course, that would obviously encompass the prophylactic antibiotics, the cycloplegics, and the lubricating drops. So that is basically that you have to observe the fact that this is the conventional treatment. We have antibiotics, cycloplegics, as well as lubrications. This is a treatment that is generalized in cases of ulcerations. And then we have the topical steroids as well over here. Finally, we have the systemic medications being prescribed. We have immunosuppressant drugs, doxycycline. Oral vitamin C is sometimes given for the regeneration of the epithelium. Surgical measures would consist of the excision of the adjacent inflamed conjunctiva, as well as a bandage is sometimes used for the contact lenses or the conjunctival flap. The tissue adhesive or the peripheral tectonic keratoplasty is performed in these cases. So you would basically have the fact that we're going to basically give aids towards the protection of the corneal epithelium and stop the exposure of the corneal epithelium to the environment. This would be the main aim towards the surgical measures over here. Talking about the Mooren's ulcers or the summarization of these kind of ulcerations, these are again one of the fact that you have to keep in mind that these are the marginal kind of ulcerations that you would observe. They're going to affect the margins, not the central portions of the cornea in these cases. The Mooren's ulcers and how do you treat these Mooren ulcers is very important. We will be prescribing the steroids instilled every 2 to 3 hours. The immunosuppressive therapy with the systemic steroids is done. Immunosuppression with cyclosporines, soft contact lenses are prescribed. And along with that, we are going to perform the surgeries, which are basically the lamellar surgeries, and the full thickness corneal grafts are also done. If there is an excessive damage of the cornea that the patient has been subjected to, and that is hindering the visual acuity of the individual. We have the rosacea keratitis. Usually the patients would be giving you the history of acne rosacea. There would be a mallar and a nasal rash, and that is the characteristic feature of these patients who are suffering from rosacea keratitis. Facial eruptions, extreme acne is observed in these patients. Chronic blepharoconjunctivitis, the yellowish white marginal infiltrates, small ulcerations, punctate ulcerations are noted down, and we have the heavily vascularized corneal margins. So this would be the features that are associated with the rosacea kind of keratitis in these patients. The treatment would be to treat the acne, first of all. The local treatment would be consisting of topical steroids, of course, and the systemic treatment would consist of the systemic tetracyclines that are given. Obviously, you can use the oral or the IV use of the tetracyclines, usually thrice a day dose that is observed in these patients, 250 milligrams thrice a day for 3 weeks, and then TDS for 3 weeks and BID for 3 weeks as well. This is one of the regimens. Once a day for 3 months, this is a slow regimen that is usually, for example, doxycycline is used in these patients and is given for 3 months and just once a day. So these are some of the treatments or the treatment regimens that you would prescribe to in patients with rosacea keratitis or acne rosacea. So in this lecture, basically, we just summarize the causative factors towards the development of the trophic ulcerations as well as the marginal ulcerations and what are the different classifications and how do you go about and treat these cases that is discussed over here. So that is the end of this lecture. Thank you for watching sqadia.com.